so much to Lorraine for being our speaker. So my name is Adam Leventhal. I am the director of the Institute for Addiction Science at USC. We are a interdisciplinary, or transdisciplinary, I should say, research unit involving, I think, 6 or 7 schools across USC. And we're trying to change the paradigm for addiction research and education and kind of merge across disciplines. So we have more than 50 members, many talented faculty members across different parts of USC who are talented scientists, educators, and in this case, clinicians and scientists. And so I'm really excited to introduce Lorraine to y'all. So Lorraine's like one of the most impressive people I've ever met. And so I just, maybe that's just because I'm just not used to pediatric surgeons because they're all pretty gnarly, but she is one of them, and she's a pediatric surgeon scientist. So she is an assistant professor in the Department of Surgery at Children's Hospital, Los Angeles, and has cross-appointed in the Keck School of Medicine, and also a secondary appointment in the Department of Preventive Medicine. She's from Seattle, Washington. She has a BS in Biochemistry and Cell Biology at UC San Diego. And then she did an MD at UCLA, and then a general surgery, I guess it's probably residency, right?
Yeah, that's right.
At UCLA. And then she went to Nationwide Children's Hospital in Columbus, which is one of the, I guess, the meccas for pediatric surgery and pediatric surgery research. And she trained there for her pediatric surgery fellowship. She also was a Robert Wood Johnson clinical scholar. She has a master's in health services research from UCLA in the School of Public Health. So she's truly a physician scientist. And I've had the pleasure of working with her over the past 3 years since she's been here at USC. And right now she's interested in the intersection of health services and pediatric surgery, and with an addiction kind of angle. Noticing a lot in her clinical practice and in the field, the provision of opioid prescriptions and for youth, and she's interested in pursuing this from a research angle so she can help change the paradigm and provide evidence to help pediatric surgeons, and then also, I think probably all health professions in terms of their opioid prescribing practices to kind of hit that nice, I guess, middle ground where you're treating your patients' pain effectively, but you are not increasing risk for use, abuse, diversion, and whatnot. So she's going to talk today about her research that she started here at USC. And so with that, let's welcome Dr. Lorraine Kelley-Quon.
Hi, everyone. Thank you, Adam, for that very, very generous introduction. I'm really excited to be talking today. I'm going to be presenting some exciting preliminary results from an adolescent study I'm doing at Children's Hospital. And as in any good research, this is stimulating a lot of additional questions, and I think would be sort of the perfect avenue for further collaboration within IAS. So thanks for inviting me to this forum. I also want to thank everybody that submitted questions ahead of time. There was actually a lot of clinically relevant questions that people submitted, so I actually changed my talk in a little bit to spend the first part of it addressing some of those more clinical questions about opioid prescribing in adolescent populations, and then going into some of the research projects that we're running. So I'm going to spend the first part of this talk reflecting on a project I was involved with the American Pediatric Surgical Association to create opioid prescribing guidelines for children after surgery. This is a multidisciplinary, multi-institutional systematic review that was performed across 9 different institutions. And a lot of the data that we reviewed in this systematic review is informing current efforts in something called opioid stewardship, or prescribing opioids in a responsible way so that you can maximize pain control and at the same time minimize risk. And then finally, as I mentioned before, I'm going to dedicate the last part of my talk to sharing some of the new data that I have from the Adolescent Postoperative Longitudinal Opioid Study at CHLA, or Apollo as we call it by short. So I'm also involved with the Youth Opioid Response Grant that was given to CHLA. I'm on the advisory committee for this grant. And basically this grant is giving CHLA resources to develop a media campaign that's targeted both at providers and then also at teenagers to increase awareness of the risk of opioid use and also increase awareness about the resources that are available for teen populations. So one of the things that we did in development of this media campaign is survey CHLA providers about their perceptions of opioid use and misuse in teen populations. So we asked them the question, do you think prescription opioid misuse is a problem for adolescents? And I want to focus your attention on the right side of your screen, and those are all the physician responses. So unfortunately, only half of the physicians in this survey thought that yes, opioid misuse is a problem for adolescents. So that means there is a huge lack of understanding about the risks associated with opioid use in teenage populations that really needs to be addressed both at the provider level and then also at the family level with teenagers and their parents. So as many of you probably know, opioid poisonings, both accidental and non-accidental, have been increasing over the past several years, specifically in the older teenage populations, 15 to 19 years, conveyed in the tan bars here, but then also accidental poisonings in the youngest age bracket, the 1 to 4 years of age, has also been increasing. And a lot of this is due to the overabundance of opioid pills in the community. There was some early improvement in 2012, 2013, 2014, where opioid-related deaths in pediatric populations were on the downswing, but they've actually gone up again recently, and this is thought to be due to the emergence of synthetic fentanyl in a lot of agents out there. So this is definitely not a problem that's going away. So healthcare providers do need to be aware of this. One of the reasons that opioids continue to be a problem in pediatric populations is that opioids are commonly prescribed for children. I'm a pediatric surgeon. There are lots of surgeries that result in an opioid prescription at discharge from the hospital. So in this graph, you can see multiple surgeries that are performed in children listed, and then on the x-axis, and then on the y-axis, you see initial prescription total oral morphine equivalents. So this is a measurement of the total amount of opioids in a given prescription. And you can see there's huge variation between procedures and overall. And ultimately, this contributes to excess opioid pills in the community. So these are results from a survey that was done in Michigan. They surveyed 635 families in the Detroit area and asked them if they had any opioid pills in their house. And about 29% said that they did. And the vast majority of them said that the reason they had an opioid pill was because their child recently had surgery. Now your question is probably, well, if they have these pills sitting around, what happened when they were done using them after their child's surgery? Most people just kept it in their house, 47%. Some people threw it in the trash, and almost 10% don't even remember what they did with those extra opioid pills, and 6% reported that they used it for other family members to treat, which is diversion. So there's a huge excess of opioid pills in the community. A lot of that is due to overprescribing from surgeons, and as we outlined earlier, opioid poisonings, accidental and non-accidental, are on the rise in pediatric populations. So this is a big problem. So as I mentioned before, with this in mind, the American Pediatric Surgical Association put forth a goal of developing opioid prescribing guidelines. So I was fortunate enough to get funding through a team science grant provided by the Southern California CTSI for the project that I'm going to be talking to you about. So myself, in addition to multiple other pediatric surgeons, pediatric anesthesiologists, and also nurse practitioners, PAs, we had general surgery residents representing as well, in addition to Dr. Matthew Kirkpatrick, who's at USC, an addiction scientist. Basically, we all got together and reviewed all of the literature relevant to prescribing opioids in pediatric populations undergoing surgery. As you can see, this spans a breadth of institutions and also a breadth of disciplines, all of which interact with children during their surgical recovery. So basically, over the course of 9 months, we reviewed about 14,000 manuscripts relevant to this topic. And then we came together in Boston last year. We sat in a room and then for 2 days hammered out what evidence-based guidelines should look like for children who need opioids after surgery. The first question that we asked with our systematic review was, what are the risks of prescription opioid use in the pediatric population? When you think about risks for adolescents and children using opioids, there's like 3 main buckets you should think about. So the first is risk of misuse and abuse. The second is the risk of diversion. And the third is the risk of chronic use or continued use 3 months after surgery. The vast majority of the data that we reviewed was from the National Survey on Drug Use and Health, also known as the Household Survey. This is a nationally representative survey in which they survey teenagers. They specifically target the 12 to 17-year-old age bracket, all the way up through adulthood, and they ask questions about all different types of substance use. And this survey has been conducted annually since about the late 1960s, so we can get a very clear picture of the breadth of opioid use and misuse in the US population from this survey. Now, of all of the papers that we reviewed for our particular project, I think this is the most telling graph that we found. So on the x-axis, you can see years over time. It's a little small. So this ranges from 1965 all the way up to 2002. And on the y-axis, you see the historical trends and lifetime prevalence and incidence of prescription opioid misuse among youth. So this is the 12 to 17-year-old age bracket. And you can see that it hovers around 1 to 2% from the 1960s all the way up to the early 90s. And then you see this exponential increase in the overall prevalence of opioid misuse in the teen population. And this perfectly coincides with the opioid epidemic that we saw in the United States and the emergence of pain as the 5th vital sign and physicians overly aggressively prescribing opioids to treat pain. Now, this is particularly important to understand that the prescription opioid misuse increases in adolescence. As you follow these cohorts and look at the different age brackets, you can see that it increases from 12 to 13, 14 to 17-year-old, all the way up into early adulthood. And then the overall past year opioid misuse in these populations decreases as people age out of those brackets. As opioid misuse increases, so does the incidence of opioid use disorder, which you can see increasing in overall percentages with each additional age bracket. Now, this is a study that we actually did not include in the systematic review as it came out afterwards. But this is a study I did with Dr. Leventhal and his group at USC, looking at just over 3,000 teenagers in the LAUSD school district. This study was a longitudinal cohort study following kids all the way from freshman year through senior year, asking every 6 months about substance use. And in this study, we were able to identify a prospective association between initial opioid use and later heroin abuse, which hadn't been done before. So we talked about the specific risks of opioid use, leading to misuse, abuse, and even heroin use in adolescent populations. The next thing we worry about is opioid diversion. So this is also data from the household survey. So when a teenager answers the survey and says, yes, I've used opioids recreationally, the next question they get is, well, where did you get those opioid pills from? And you can see about 25% get their opioid pills from a doctor, and then another 40% get them from a friend or relative. Well, if they answer yes, that they got it from a friend or relative, the next question they get is, well, where did that friend or relative get those pills from? And the vast majority, over 60%, also got it from a doctor. So that means that opioid diversion in the adolescent population is a single step from the provider. This is really profound, especially if you're just writing one opioid prescription after a single operation. The third thing we worry about in the teen population is the emergence of new chronic opioid use for opioid naive teenagers. So that is an adolescent who's never used opioids before, has a surgery, gets an opioid prescription, and then 3 months later they're still using it, which is a point when you really shouldn't have any surgically related pain and shouldn't be using opioids any longer. Now, why does this happen? Well, opioids inherently are very addictive. The probability of long-term opioid use increases most in the first days of therapy, even after only 5 days of opioids are prescribed. You can see on this graph that as someone goes from taking 5 days worth of opioids to 10 days worth of opioids, their likelihood of continued use at 1 and 3 years significantly increases. And this relationship carries all the way through using opioids for 30 days, which is ironically the most common days use of prescription that is prescribed for opioid pills in general. The most common reason that a teenager would get an opioid prescription is after they have their wisdom teeth extracted. Not everybody gets an opioid prescription after wisdom tooth extraction, but of all the reasons that a child gets one after surgery, this is the most common. Compared to children who do not get an opioid prescription after wisdom tooth extraction, children who do get a prescription have a significantly higher risk of persistent use at 3 to 6 months after surgery, not surprisingly. The kids who are at most risk for that chronic use after wisdom tooth extraction are older children. There's a slightly significant increased risk for young women. Adolescents with diagnoses of chronic pain, depression, anxiety, and already have a history of substance use disorder also have a higher likelihood of continued opioid use after wisdom tooth extraction. Also, if they have a benzodiazepine stimulant or another sedative that's prescribed, they have an increased likelihood of use. This is actually really problematic because you're really not supposed to be mixing benzodiazepines with opioid prescriptions. And also of note, a lot of people think, oh, if you have impacted molars, or impacted wisdom teeth, and you have a lot of pain after surgery, therefore those kids are the ones that we really have to give opioid pills to, and there's really no increased likelihood of them using opioids for a longer period than children who don't have impaction. And we see this persistent likelihood of conversion to chronic opioid use in multiple pediatric surgical populations. So you can see that the prevalence of persistent opioid use after surgery ranges from about 2.7% for children who undergo orchiopexy for an undescended testicle, all the way up to 15% for children who undergo a colon resection. So on average, the prevalence of conversion to chronic opioid use is 4.8%. And I want you to remember this number because it's going to be relevant to the study that we're doing at CHLA later. The next question we asked with our systematic review was what non-opioid regimens are effective to manage postoperative pain in children. And this included a review of oral, IV regimens, and also regional blocks. And I'm not going to go through all of the different papers that we looked at, but there is a very robust literature dedicated to non-opioid regimens being effective to manage pain in pediatric surgical populations. All these regimens decrease opioid use overall, or they provide equivalent pain control. Obviously, these decisions have to be made between the surgeon and the anesthesiologist and the rest of the care team members, but there is very, very solid literature that there are multiple different modalities to decrease need for opioids in the perioperative period in children. The final question we asked in our systematic review is what teaching and preparation on opioid use after surgery should be provided to patients and families. So this was actually a really challenging question to answer looking at the literature, because there's been an entire body of literature from the 90s and early 2000s that were dedicated to educating families about how to give their children opioids around the clock so that their children didn't have any pain whatsoever. So this particular review of the literature was very limited to the last 10 to 15 years. And this is an area that in particular really needs robust, multidisciplinary research dedicated to it. But in general, one of the most common issues that parents are worried about when their child is undergoing surgery is that their child's going to have pain. Parents have said universally that they want to get educated on how to manage their child's pain, and they want to get that education actually before the surgery, not after the surgery happens when you're trying to get all the paperwork and get discharged from the hospital. The reason is a lot of parents want to be able to go to CVS or the drugstore and get cold packs and Tylenol, and so when they come home from the hospital after surgery, they feel prepared. So all of this literature is really highlighting an overarching principle of opioid stewardship. So you've probably heard of the term or the phrase antibiotic stewardship. So we use this phrase a lot in medicine. And it just basically means that if someone needs antibiotics, they should get a specific antibiotic that's tailored to whatever infection they have. They should have for a limited amount of time. And in doing so, you decrease the likelihood of antibiotic resistance in the community. Well, those same principles apply to thinking about how to safely prescribe opioids to children and adolescents, and that we need to recognize the risks of opioid use, maximize non-opioid analgesic use, and educate families on safe usage. So I'm happy to say that our efforts with the American Pediatric Surgical Association expanded outside of our society and were embraced by the American College of Surgeons. This is a handout that the American College of Surgeons created for children and teens. It's a handout that can be printed offline. It's something that's present in outpatient clinics, and it's supposed to be both for providers and then also for family members to provide information on how to safely manage pain in the perioperative period. And I'm happy to say that the vast majority of information and statistics in this pamphlet was informed by the systematic review that we did with the American Pediatric Surgical Association. One thing that's very exciting is that this concept of opioid stewardship is really gaining a lot of ground in different hospitals. So at CHLA, we are a member of the Western Pediatric Surgical Research Consortium. So this is a multi-institutional surgical collaborative in which we do a lot of research projects together. A lot of things in pediatric surgery that we treat are really rare. So it's hard for an individual institution to do a very robust study to generate data that influences how we practice. So the CHLA, in addition to the 9 other hospitals listed here, we frequently collaborate through this consortium to generate new knowledge for how to treat children who require surgery. And specifically, opioid stewardship was one of the things that was recently identified as something that all consortium members wanted to address through our collaborative. So the most common operation and the most common diagnosis that I care for is pediatric appendicitis, and I treat this with a laparoscopic appendectomy. Across the board in all of these hospitals, this is the most common surgery that we all do. Typically, the surgery involves 3 less than 1 centimeter incisions, and a lot of kids undergo this operation and they go home the same day. So we thought this would be an ideal target for optimizing opioid stewardship among our 9 different hospitals. When we met around the table and we talked, we found that 4 out of 9 of the hospitals had already eliminated opioids after appendectomy, CHLA being one of them. But at the remaining hospitals, there was significant variation between sites. Some sites gave opioids for only a handful of days after surgery. Some sites, if they had patients who lived very far from the hospital in rural areas, gave more opioids to those patients. And some sites said they only gave opioids to teenage patients, which ironically are some of the highest risk patients to give opioids to. At the end of the day, all of the consortium members agreed that eliminating outpatient opioid prescriptions after appendectomy was what all pediatric surgeons should be doing. And so all of us committed to eliminating opioid prescriptions after appendectomy for 6 months, from July to December of 2019, and we tracked our outcomes. And for the hospitals that were prescribing opioids after appendectomy, the overall rate of opioid prescribing went from 32% to 3%, which is huge in just a 6-month amount of time. And one of the more interesting things that happened with this project is surgeons practicing at hospitals in which they thought nobody was going home with an opioid prescription, actually there was a good number of kids who were going home with an opioid prescription because of the variation in care between the different surgeons at those institutions. So this is huge because collectively between our 9 institutions, we treat about 4,500 children for appendicitis each year, 2,588 of which were at hospitals that were previously prescribing opioids after appendectomy. So even between our consortium, we made a huge effort in a step towards responsible opioid prescribing for this very large pediatric surgical population. All right, so I'm going to dedicate the rest of my time to talking about the project I've been doing over the past year and a half at CHLA. As Adam mentioned, I'm one of the KL2 scholars, and this is my project that I've been doing with that program. This is the Adolescent Postoperative Longitudinal Opioid Study. So there's the 2 primary questions that we're asking with this study. The first is, does excess opioid prescribing, which we know occurs because we see it in all of the studies looking at opioid prescribing for children who undergo surgery, does that impact postoperative opioid misuse, diversion, and chronic use in adolescent populations? And then the second question that the study is answering is, how do behavioral health factors impact prescription opioid use after surgery? So this is a prospective longitudinal cohort study examining postoperative opioid use. And we're using both team reports of opioid use and actually what their parents are saying as well. We're including adolescents and young adults who are 13 to 20 years of age who come to CHLA, and they undergo one of 8 procedures commonly associated with an opioid prescription at discharge. Now, we specifically chose these procedures because they're painful procedures. So a procedure like a laparoscopic appendectomy for pediatric appendicitis, that in general, that shouldn't be getting an opioid prescription anyways, but these are painful operations and children can't just be taking Tylenol immediately after these operations. So they should get opioid prescription, but they should get it responsibly. And we'd like to do that, know how to best do that for our population. The methods that we're using for this study are primarily retrospective and prospective medical record review for all the enrolled patients. And also we're using a survey methodology at multiple different time points in the perioperative period. So here's a schematic of how an individual patient sort of progresses through our study and how the different points that we collect data at. So if a teenager comes to our outpatient surgery clinic, and then there is a conversation between the surgeon and the family, and there's a decision for that child to undergo one of those eligible procedures. Our team is then paged, and then we approach them in clinic after their surgical appointment, and both the parents and the adolescents are administered a baseline survey. Now, after they're enrolled in the study, at some point they'll undergo surgery, and some kids undergo surgery a week or 2 after enrollment. And sometimes it takes a few months. These are elective operations largely. So a lot of times parents and kids want to coordinate it with breaks from school. Fortunately, I stopped enrollment before I ended enrollment before COVID, so I haven't been delayed by that. But then once they get their surgery, they may stay in the hospital afterwards, or they may go home the same day of just as that they had the surgery. And then they get 2 follow-up surveys. We're doing most of them via either text or email, some of them over regular mail, at 30 days and 90 days, and we ask about actual opioid use. And then we're also collecting data from the electronic medical record through this entire process. So these are the survey elements that we're capturing in the baseline teen survey. So you can see that there's multiple health behavior elements that we're screening for. These are all things that have been associated with opioid misuse in adolescent populations. We're also looking at self-reported race, ethnicity, and also measuring self-perception of discrimination and self-perception of subjective social status, which have also been shown to be associated with substance use. They're also undergoing health literacy screens. There are studies that show that decreased health literacy is actually associated with an increased likelihood of filling a prescription and also taking that prescription for a longer period of time. We also ask teenagers about their gender identity, about family history of substance abuse, and also use several screening metrics addressing personal substance abuse. Now, for the parent survey, that's before their child undergoes survey, we captured several of the elements that were also captured in the teen survey with 2 important additions. One is we also use the opioid risk tool. So this is about 10 screening questions. It's developed by CMS, and it's supposed to be used by primary care providers in order to screen patients who are chronic opioid users to see if they would have an increased risk of opioid abuse in the future. Parents also underwent a generalized anxiety disorder screen. There's some studies that show that parents who score higher on anxiety scales, their children actually take opioids for a longer period of time, even when matched based on age and surgery. Now, after a child has surgery at 30 days and 90 days, we ask about the opioid use in the home. So we ask if any family members are using their opioid pills, which would be diversion. We also asked whether or not they received any instructions on how to use the opioid pills when they're discharged from the hospital. We asked about disposal patterns. We also asked about their pain assessment. How was their pain when they immediately returned from the hospital? And then how is it on the day that they're filling out the survey? And of course, we also assessed misuse, diversion, chronic use, and the overall number of excess pills that were in the home after surgery. So like I mentioned before, I'm very lucky that I finished enrolling this study before COVID came out. So our enrollment went from February 2019 to February 2020. I think we finished on February 22nd. We enrolled 184 adolescents and 192 parents in this study. The reason there's slightly more parents is some of the procedures that we captured. There are children with comorbidities such as cerebral palsy, and they can't fill out the surveys, but we're still interested in what their actual opioid use is after their surgery. So they were included, and that's why there's slightly more parents than adolescents in our cohort. Enrollment was really good. It was over 90%. And these stats may actually changed since I made this slide, but we have 78% of the cohort completing 30-day surveys, and about 68% have completed their 90-day follow-up surveys. We've only had about 5% of cases lost to follow-up. I think that because elective surgeries were delayed for the past 2 months, our follow-up after those elective cases are scheduled may extend our data collection out into September or maybe October of this year. So these are the cohort demographics of the teen cohort. You can see that we have a large breadth of kids coming from different grades, all the way from middle school up through high school, and even some college age kids in our cohort. If you can see, one thing that's going to make this cohort unique is that there is a large Hispanic or Latino population that's very characteristic of Children's Hospital. And then the next largest racial bucket is children identifying or adolescents identifying as white race. For the behavioral health comorbidities that we screen for, the overall incidence and prevalence in our cohort is similar to that in the general population, except with the exception of ADHD. There's actually, the overall prevalence is around 10 to 15% in the general population. It's higher in our population, but that's also characteristic of being in a children's hospital with children with other comorbidities. One thing that, even though we're not done with our analysis, it's going to inform my future clinical care and research, is that the health literacy screen, 13% of the teenagers had inadequate health literacy, and 32% had scored marginal in their health literacy, which means these teenagers that I'm counseling in clinic, like almost half of them are not getting all the information that I'm sharing with them. And I think that has really profound implications for, you know, going forward for any interventions that we design for teenagers and their families. Almost 20% of teenagers are coming from families with a history of alcoholism. Also, there is a good number with a history of substance abuse and opioid use and misuse in their families. But overall, if you look at our drug abuse screening test and the prevalence of cannabis use and alcohol use, it's actually pretty low in the population that we recruited. And then looking at the parent cohort, probably not a surprise, but the majority of parents we recruited in clinic, 3/4 of them were mothers, which is not a big surprise. Similar racial and ethnic breakdown. The opioid risk tool, about 4% of parents were moderate risk. So we're going to be interested to see and what happens with those opioid pills after surgery in those households. And a significant amount of parents screen positive for moderate or severe generalized anxiety disorder. Some of that may be further augmented by the fact that they just learned their child requires surgery, but more to come on that. And the health literacy levels were very similar in the adult cohort as they were in the teen cohort. And then when you look at annual household income and also highest education completed in this cohort, there's a bimodal distribution in the lowest and highest brackets. So looking at preliminary data from our 30 and 90-day surveys, it's very interesting. So on average, the parents are reporting that their child's pain is at a level a little higher than what the teenagers actually saying. The parents also are reporting that their kids are taking opioids for a longer amount of time than the kids are saying. But in general, they both agree on a total number of leftover opioid pills, that on average, each child who's getting an opioid pill or an opioid prescription in this study has 15 pills left over. So in total, that has led to 2,098 excess pills in the CHLA community. 14% of the cohort ended up refilling their opioid prescription. And I was really surprised by this. Misuse and diversion is actually really, really rare in this cohort. And we'll talk a little bit about that in a little bit. But also, what's interesting is that the incidence of new chronic opioid use, so that's a teenager who's never had an opioid who gets a surgery and is still taking their opioid pill 3 months after surgery, it's 7.5%. And if you remember, and the previous slide I showed, on average, it should be closer to 4 or 5%. So this is an increased overall prevalence of, or increased incidence of this particular outcome, at least in our preliminary data. So then the question is, well, why is misuse and diversion so infrequent in this cohort if I just presented all this data to show you that it's so common in teenage populations? Well, there's a large number of Hispanic and minority enrollees in this population, and not everyone actually got an opioid pill after surgery. So there are some studies that show that non-white race is associated with a decreased likelihood of getting an opioid prescription. And also Hispanic populations in particular have really low rates of opioid misuse and abuse in their teen populations. The other thing that could be happening is they're getting a survey from a surgeon from the hospital where they receive surgery. So as opposed to a surveyor from the government. So they may not be as inclined to be as truthful if they see that this is a survey about opioid use and it's coming from a doctor. Or it could be that that opioid misuse and diversion actually happens outside of the window in which we're looking with our particular study. And what's going to happen in the setting of COVID-19, now that everybody's at home and they have these excess opioid pills, are they all going to start sharing now? I don't know, hard to say. But one thing when looking at our preliminary data that I think is particularly of note is that chronic prescription opioid use appears more frequently in this cohort than in previously described cohorts. This is problematic because it can lead to chronic use in adulthood and is associated with opioid use disorder. And it's particularly relevant issue at CHLA because pediatric specialists who care for teens really don't know what to do with a child who is addicted to opioids. Going back to the Youth Opioid Response Provider Survey that we discussed at the beginning of this talk, we asked CHLA providers, how comfortable are you referring to adolescent patients to medication-assisted therapy? And if you look at the left side of your screen at the physician respondents, over 40% of physicians said they were either very uncomfortable or uncomfortable doing that, which is a problem if we have an increased number of children developing chronic opioid use after surgeries they undergo at our hospital. So something that I'm thinking more and more about as I go into the next phase of data analysis and understanding the implications of our Apollo study is that really this points to a new paradigm for chronic opioid use in adolescents. And what is probably happening is that there are different aspects of health behavior, race and ethnicity, and health literacy that all feed into the likelihood or that a child receives an opioid after surgery, how long they take that opioid, and their likelihood of developing chronic opioid use afterwards. And I think all of these findings really point to how multidisciplinary collaboration is really needed to answer these questions in this very vulnerable population. So I'm particularly excited that I got to present this at IAS today because all of you listening are from multiple different fields. And I really, at this point, am looking for other collaborators and how can we use this data to look at disparities in opioid prescribing and outcomes for children undergoing or adolescents undergoing surgery. Also, there seems to be a sort of disconnect between what the parents are saying after surgery and then what their teenagers are saying is happening to the opioid pills after surgery. I think this lends itself to very interesting dyadic analysis that I'm looking for collaborators on. Also, as I highlighted, there are a lot of excess opioid pills in the homes of children who underwent surgery at CHLA. And this really lends itself to implementation science methods for how can we change practice to ensure safe opioid disposal. And really, coupling of this new chronic opioid use in teen populations needs to be paired with appropriate MAT referral. So I'd love to talk with people about future collaborations in that respect. I think we're coming up on time and I wanted to leave enough time for questions. So I'll stop here and open it up for questions. And thank you so much for having me talk today.
Thank you, Dr. Kelley-Quon. That was amazing. Really appreciate that. We do have a couple of questions. I want to tell everyone how the question and answer works right now. There is a Q&A function at the bottom of your screen. You can utilize that, or if you click your name under the attendees, just raise your hand and I will unmute you and you'll be able to ask your question live. First question, as parents, how can we prep our kids for this epidemic rather than falling victim to it? I know you mentioned a few things that parents need to be aware of and some of the risk factors of parents who might keep pills in their home for a little bit too long, or look at their kids' pain even differently than their kids look at their own pain. But what else can we do as parents to make sure that our kids are only taking the appropriate amount?
Well, I think First, it starts with that conversation before a child even undergoes surgery in my specialty, and talking to the family. I typically, pain is one of the things that I address in my preoperative evaluation appointments, and I talk about how pain is going to be managed in the hospital and afterwards. And I could tell you the vast majority of families are fine with not getting opioids after surgery. But they are worried about how to manage their child's pain. So as physicians, we can't just say, oh no, opioids, we don't want you to get addicted. We need to provide alternatives like Tylenol, ibuprofen, ice, and other things that can be useful. I think in terms of how parents can get ahead of it, I think I'm a big fan of opioid disposal. Let me go ahead on, so if you go to the DEA website, they have a little tracker where you can put in your zip code, and then it will pull up the closest secure opioid disposal bin. And after a lot of work, I was able to get one installed at the Children's Hospital, and we're actually the first children's hospital in the Western United States to have one. Most children's hospitals don't have one on site. So it's a really useful tool. And once your child is done with their opioid pills, they should just get out of the house. They shouldn't be used by anyone else.
Yeah, absolutely. Thank you for sharing that. Our next question is about the nature of the problem and how we need a transdisciplinary approach. So how could providers and social workers work together to combat this issue with our adolescent populations?
So I think that we could really use social workers' help developing educational materials. As I mentioned earlier in the talk, there's really just not good evidence out there for how to educate families on the risks, on non-opioid alternatives, and secure opioid disposal and safe usage. One example would be that if you survey parents after their child receives an opioid prescription, the vast majority of them have received no education on the signs of opioid overdose, or a child unable to breathe and being very somnolent. So we haven't even fully educated families on what it looks like if your child is taking an unsafe amount of opioids. So, and that goes all the way to then how you dispose of them when you don't need them anymore. So I think social work, we as physicians could really use help from social work in that educational component.
Okay, thank you. You touched on one question that came up. We know there's a difference between dependence and addiction, but we lack a lot of education about what dependence looks like, physiological dependence to an opioid. So could you kind of describe some of the symptoms a parent might see in a child who is becoming dependent on the opioid?
Well, I can say it's a little bit outside my realm, as typically the opioid dependence, those kids are cared for who develop opioid dependence are cared for by our pain management specialists. But typically the opioid dependence is marked by symptoms, if the opioids are stopped, like irritability and things like that.
Okay, great. Another question here. How can I support an adolescent client who just received a prescription for an opioid?
Well, I think, again, that goes back to having that teenager and also their parent have a conversation with whoever prescribed it and ask when it needs to be used and when it can be safely disposed of.
Okay. We have another question here from Dr. Leventhal.
Okay, I'll ask it. Yeah. Thanks, Kristen. Great talk, Lorraine. So what are your, I know you're interested in this and doing some research in this, but kind of what are your global thoughts about opioid misuse amongst youth, and kind of like how it intersects with the pandemic in all the various ways, stress, kind of being cooped up inside, maybe even, having COVID, getting, and being infected with it, a family member. Kind of what are your general thoughts as a concerned kind of pediatric health practitioner?
Well, I think that my concerns echo a lot of my colleagues, and we get concerned about increasing substance use problems with everyone cooped up at home and separated from their loved ones. And I think that, I mean, I heard it on NPR today, they were talking about whether or not suicide rates are going to go up with COVID. The two things that stress people out the most and make them think about suicide is economic insecurity and also social isolation, like two things that are hallmarks of COVID-19. So children, even adolescents, they feed off of their parents. So I think that all of these things could potentially be augmented, worrying about opioid misuse and diversion during the pandemic, even if it's just simply because there's more stress in everybody right now. But it's also probably because people are going to be less likely, if they have back pain, to go to their doctor and get evaluated. They'll probably stay home and use those leftover pills that they've had sitting around from surgery.
Thank you, Adam. Any more questions from folks in the audience? Again, you can raise your hand or use the chat function. I did have one question that might be a little out of your purview, but what do you suggest?
Andrew Kinoshita, I got a message that he had a question.
Perfect.
I just got but I didn't see the question.
Oh, he raised his hand. Andrew, you are free to talk.
All right, thank you, Dr. Kelley-Quon. I was wondering, you mentioned how opioids were being unknowingly prescribed by doctors. Could you tell me? I don't really understand how that aspect works.
I can tell you. I used to be one of those doctors. Unfortunately, in medicine, you learn what people before you learn habits of the people who came before you. So when I was in my surgery residency, and if I went on a new rotation, and say this is an outpatient surgery building, and I'm doing a lot of outpatient procedures, I asked the resident who came before me, like, I would ask them, what does each surgeon want? How can I get the patients discharged and make everybody happy? And one of the things was make sure that you write those opioid prescriptions ahead of time. And so I wrote opioid prescriptions just because that's what I was told to do by my predecessors. I also usually, I like to share this story. I had a teenager who was in a car crash that I took care of when I was a fellow. And there was a delay in him leaving the hospital when he was ready to go. And I asked the intern what was the delay, and he said, oh, he wouldn't take his opioid prescription. And I said, why? And he said, apparently my intern, who was a young trainee, had written an opioid prescription, and he had handed it to the patient, who was a teenager, and the teenager said, oh, I'm not comfortable having this in the house because both my parents have substance use issues, and I'm just not comfortable having all these opioid pills in the house. And I asked my intern how many pills he had written for, and this kid had rib fractures, and he had written him for 90 tabs of oxycodone. And I said, why did you write him for so much oxycodone? And he said, well, I just came off of my surgical oncology rotation, and I sent all those patients home on 150 tabs of oxycodone. So I thought this would be reasonable. So it goes back to just basic education in our surgical training. We're not trained what is an appropriate amount of opioids to prescribe, and we just do what the people before us did. And it's a huge area that needs improvement within surgical education.
All right, thank you. That clears up a lot.
That's a good question. There's another Q&A? Okay. Go ahead, Kristen. I don't know if you've asked from Jacqueline.
Yes. What are some ways we can treat opioid use disorder, I imagine, within the adolescent population?
Well, it's interesting. That's one of the things that the Youth Opioid Response Grant is hoping to address. So medication-assisted therapy is actually something that a teenager can actually undergo that therapy and have it, have it be separate from like their parents consenting. So there are laws within California that teens can get substance use disorder treatment without having to share that information with their parents. So I think that there needs to be more awareness of the resources that are available. And then also, physicians in general, myself, before I started thinking about this problem, we don't think about chronic opioid use as surgeons. We think about identifying a problem, fixing it, and moving on. And I think it's something that within the spectrum of care and bringing a child to full recovery that we need to think more about, especially if there's more and more kids developing chronic opioid use in our surgical populations.
Thank you.
So kind of like, I don't know how many trainees we have on. I didn't look at the participants.
Several.
Well, it's hard to tell. I guess so. I think one thing that always interests me too is just about, training as a physician scientist and balancing a heavy clinical workload with doing research. I know like you're just a few years in right now, but like, do you have any words of wisdom for the kind of next generation of clinician scientists?
Well, in some ways, I feel like I'm a bit of a job creator because I have people help with childcare. So I have a 5-year-old and an 8-year-old, and we have a woman who's a pre-dental undergrad who helps with childcare. I'm actually in my office at CHLA because if I was at home, my kids would be, regardless of anything, coming in and asking me questions about Star Wars and Godzilla. So knowing when you have to fully separate yourself from family and having resources to support that is helpful. I also wake up really early, which is the quiet time in my house. So I can actually, that's when I do my best, like thinking and writing. And then I think really, at the end of it, it's a lot of it for me is tapping into like being really aware of what brings me joy in doing research and having that be the focus. Because you can get distracted by a lot of things like promotion, faculty promotion, and all of the clinical responsibilities. But I personally try to focus on the things that I find most rewarding about my research, which I've shared today, but then also my clinical work. And I really try to not get overwhelmed by those little tasks that you get distracted by every day.
Thank you.
Good advice.
That is good advice. We have time for one more question if there's another one.